It's going to be another interesting session. It's on a new primary care pathway for DVT treatment. We've got two speakers. They're going to sort of be a double act. Dr. David Russell, who's prescribing lead in Darlington CCG, and Andy Reay, who's a senior medicines optimisation pharmacist for the North of England Commissioning Support. With no further ado, I'll let them crack on and do it. Okay.
Thank you very much. We'd just like to thank Bay for the opportunity to present our work. We're very proud of the work that we've achieved in the last year. Last year we actually presented at the commissioning show a pilot which we'd run in Darlington, but we've now turned this into a mainstream service across County Durham and Darlington. We just got the go-ahead for County Durham just literally last week. So it's a mainstream service now.
Thanks, Andy. My name's Dave Russell. I'm a GP in Darlington, been there since 1986, and as well as being a GP in Darlington, I'm also club doctor for Hartlepool United. That's one of my passions. And I keep on waking up each morning, looking at the newspaper, hoping to see this next slide, and hoping that Hartlepool will beat Barcelona 5-0 in the final of the Champions League, and it hasn't happened yet. Anyway, you're not here to listen about that. You're here to let me talk about, and Andy talk about, drivers which led us to redesign our DVT pathway. And it goes back to November 2011, when around in my house was myself, a pharmaceutical advisor, and another GP, just brainstorming and thinking of ways that we could yet make more savings with cost-effective medicines and quality evidence-based medicine. And one of my colleagues said, well, what if dabigatran, which had just been launched recently, could be used instead of those really expensive low molecular weight heparin injections? Sound like a really good idea, except it wasn't licensed, so end of story. But the Scottish came to the rescue, because in January we became aware of the fact that the SMC had actually approved rivaroxaban, which was another novel anticoagulant, for use in NHS Scotland. And we realised that it had actually been licensed for treatment in the UK of acute DVT in December 2011. So we could absolutely see patient benefits, not having to have those injections and be initiated on warfarin. We could definitely see healthcare professional benefits, not having to kind of deal with those issues, and cost benefits, which you might find surprising given the fact that these medications are quite expensive, but definitely are cost benefits. We'll come on to that in a few minutes' time. In Darlington, what was really a great start was the fact we had an existing locally enhanced scheme, which was an existing DVT pathway. So when a patient came in to see us with a pathway, with a DVT, we put them into an existing DVT pathway. So that was a really great head start. Having an existing pathway that we didn't like in Darlington was an even better head start. And the reason is because when someone walks in to your morning surgery on a Monday morning with a swollen calf, this one here is the one with the DVT, you know it's not going to be an easy consultation. It's a bit of a heart sink. You know that's never going to take place in 10 minutes with the existing pathway that we had. Because in the existing pathway, they would get a handheld record that you'd have to fill in quite a lot of information on. You'd have to weigh them, you'd have to arrange for injections there and then. You'd then have to arrange for scans. You'd have to make sure you gave the right strength of injection. And then you'd organise the scan. If it was positive, you'd have to stick them on warfarin. All a bit of a heart sink. And those injections are really kind of massive injections. And as you can see, having an enoxaparin injection every day is not much fun. Anyway, so Andy and I got thinking about doing things a bit differently.
Yeah, one of the main goals of the new pathway was to make sure it was safe. So the safety of the new pathway was key. It's not worked. We also had to make sure it was effective. And this was backed up by the evidence that we had from the Scottish Medicines Consortium. It sort of showed that it was safe and effective. And later, NICE obviously came out and backed that up. So we were very, we had a lot of confidence from that. I think one of the things that we need to be mindful of is when you get evidence like that, there's no need to reinvent the wheel. So that gave us the real drive to move this forward. So that was really positive that we had those things backed up by the SMC and NICE. Yeah, and it's obviously very convenient. It's a lot more convenient for patients than the old pathway. So it met all the criteria that we had. It is a relatively simple regime, certainly when you compare that to low molecular weight heparin plus warfarin, which is obviously quite complex. It's 50 milligrams twice a day for 3 weeks of rivaroxaban, and then a maintenance dose of 20 milligrams once a day. And that's the treatment to last 3 months, so it's relatively straightforward.
Bayer decided to spend millions of pounds on research into making this tablet easy for patients to take, and they really have gone the extra mile to make sure it's a very, very easy tablet for patients to swallow. And that's actually a lump of soap from my consulting room. It's not a Xarelto tablet, by the way.
Okay, on the right page.
And
so we had everything that was lined up. We had the safety was assured, effectiveness, convenience, and cost. So that met all our criteria. There are estimated cost savings which came from the SMC, and you can see those on the slide. We validated those in Darlington to make sure they fitted in with our local health economy, but it's been backed up by NICE as well. So NICE have confirmed the cost effectiveness of this pathway.
Just to say on that, I mean, rivaroxaban's an expensive medication like all novel anticoagulants. It works out at £58 a month, usual dosage, but I think what you can do is organise a rebate with CCGs to reduce that cost by 20%, which is still expensive at £47, but significantly cheaper than some of the competitors. So that was a very good bonus as well.
For the pilot, we wanted to keep it as simple as possible because we didn't want to confuse things too much. So Dave's now going to tell you what we actually did in the pilot, keeping it simple.
So what we did was basically keep exactly the same pro forma that we had for our existing locally enhanced service pathway using the low molecular weight heparin and warfarin, except just have a much easier page for patients to have, where instead of saying enoxaparin and then warfarin and things, it was just exactly the same system except using rivaroxaban. And what we did was I wrote to all GPs in Darlington as prescribing lead for the CCG, or PCT as it was, and said, look, we're thinking about doing this. Do you think it's a good idea? And I promise you that I got absolutely 100% a response from everyone saying, please, this would be a really, really good idea. We'd love you to do it. Thank you. So, I mean, we've gone through it, but the description of the pathway and the key differences are that rivaroxaban replaces low molecular weight heparin and warfarin, no need for low molecular weight heparin injections, no need for warfarin initiation and monitoring, and simple dosing schedule. And what's really important is that both the patient and the healthcare professional has choice of treatment. So, when we initiated the pilot, some GPs were slightly skeptical and still wanted to get patients on enoxaparin and warfarin, and that's absolutely fine. And some patients might not have wanted to go on a new medication as well. So they had the choice, both GPs and patients. And what happened is we approached our CCG and eventually, after many, many meetings, they eventually allowed us to have a pilot in June of last year to evaluate during in-hours, so out of hours still using the existing old pathway, for practices who wanted to do it. And all practices in Darlington did sign up to it. So, contribution to QIP agenda. Clinical effectiveness has been proven compared to existing treatment. Use of an innovative drug to improve the existing pathway. Benefits to patients, GPs and nurses, and also cost effective. So, the key learning points: get your supporting evidence together, and that we had evidence from SMC and NICE, which was very supportive and very nice to know. Andy had to develop a very, very large case for change document, which if any other CCGs want to do this exercise, it's there for you. We're very happy to share any of the stuff we've done over the last year with you if you want to do that. The work has been done, and I think with this new environment, what we need to do is not reinvent the wheel all around the country, and we've got a pathway which works. And if you want any of the information that we've done so far, we would be delighted to share it with you. And
I think an important thing that we learned was working with your acute trust very closely. We did have some issues there, and I think a lot of that are to do around the existing warfarin clinics, which were largely run by the acute trust, so that was a bit of a barrier to overcome. And of course, one thing is don't forget a formulary application. At the time, we didn't really have a formulary, but they made quite a big issue of the fact that we didn't stick in a formulary application.
Other things, I mean, I've mentioned also about speaking to your friendly Bayer representative about rebate schemes. And, I mean, I have to say Bayer have been extremely supportive during the whole process. And as a prescribing lead for my CCG, standing up here talking at a meeting sponsored by Bayer, that made me feel slightly uneasy initially, except to say that it's the only product that is licensed, the only new novel anticoagulant that is licensed for acute DVT. So the opposition, the dabigatrans, the apixabans are not licensed. Rivaroxaban's the only one. So I can sit up here or stand up here and talk about this and tell you what I think. And Bayer have been very, very supportive. There were some patient safety team concerns. We had a number of meetings with various personnel in the CCGs to try and get this agreed. One of the things they were unhappy about was the fact that rivaroxaban's a black triangle drug, or it was then. I mean, for a relatively new drug, it was actually relieved of its black triangle earlier this year, at the beginning of this year, which is obviously says a lot about the fact that it appears to be a safe medicine. So that was a good thing for us when that happened. One of the other concerns was its use unlicensed? So when a patient walks into your GP surgery with a possible DVT and you treat them with rivaroxaban, is that in its license? Because the license is for treatment of acute DVT. But I think the way around that is that you see someone and you clinically think they might have a DVT, that's probably good enough. And the other thing to point out is that the existing treatment that we had using enoxaparin, well, that's not licensed either. So I think we got around that one okay. And I think the other key learning point is perseverance, isn't it, Andy?
Absolutely.
It took quite a lot of effort to get the pilot agreed to. But in June of last year, we did actually launch it in Darlington. And just a few of the slides now looking at the evaluation of our pilot, which kind of went on until we actually launched a new pathway, which we'll talk about in a second. Over a 6-month period, we had about 76 patients put into the pilot. And you can see that there was a couple in June, at the end of June when we first started, and pretty much kind of same kind of numbers in months after that. Interestingly, more females presented to their GPs with potential DVTs than males. Don't know why that is. In the pilot, what you do is you take a D-dimer, but you don't wait for that result to come back. You see someone who you think might have a DVT, you give them rivaroxaban or enoxaparin, you then take a D-dimer, or you take the D-dimer before you give the actual tablet, but you don't wait for the result to come back. Just to let you know that a little over 50% actually had a raised D-dimer, so we were looking at people mainly who'd had raised D-dimers in the pilot. DVT or not, 11% of our patients actually ended up having a proven DVT, which is perhaps slightly less than you might expect. I think the studies suggest you might have more like 20% that you're seeing who you think's got a DVT actually end up having one. And this is an interesting one. A little over half actually went on rivaroxaban rather than enoxaparin. So the red ones are rivaroxaban, the blue ones are enoxaparin. And the next slide is quite interesting in that when we first started the study, you can see that there was a preponderance of patients going on enoxaparin. That's probably because the GPs were a little bit reticent to use this new medication. But by the end of the pilot, a couple of months ago, you can see that there was a majority of GPs and patients happy to have the rivaroxaban in preference to the enoxaparin. So, the way forward.
So after the pilot, we had to develop a new pathway taking into account NICE. We needed to make sure that was followed. And that's obviously the NICE guidance that came out just after the pilot was launched. I think it was just before the pilot was launched.
Yes, because that was a bit of a problem. We launched the pilot after several months of effort and then realised that NICE had kind of said, there's a new guidance, and we realised that the pilot we had was based on an existing pathway that had been brought about a few years previously. So I was very mindful, and Andy was mindful of the fact that we were dealing with old medicine and not latest guidance. So, who was going to do this, Andy?
There was some debate, and I think probably reluctantly, Dave and I, we didn't want the pilot work to just go by the wayside, but we decided to take this forward across County Durham and Darlington and develop an updated pathway.
Yeah, we started doing that in December. So the main changes with NICE guidance are, and there are a few changes, first of all, if you see someone now with a suspected DVT, they should now receive their diagnostic ultrasound within 24 hours rather than the old 3 days that used to be the case. So, for example, in Darlington, you can dial 111, which is the way of getting a scan, and get a scan 7 days a week. And most, hospitals should be, if you do it in hospitals, they should be offering scans every day. That's what NICE say you should do and patients should receive. This is an interesting one. You see a patient with a swollen left calf on a Monday morning surgery. You ring 111, organise an urgent ultrasound appointment for them, and NICE say they actually get a proximal leg scan. So patients must think they're quite strange and made a mistake here. But NICE actually do say if you have a distal likely DVT, give them a proximal scan. And what they say is, and here's a complicated slide, but what they say is if you see someone and they have a positive Ddimer but a negative first scan, stop your rivaroxaban or stop your enoxaparin and then rearrange for a scan in another week's time. And if it's positive, then treat them for as an acute DVT.
Yeah, and I think this is one of the areas where we got a lot of support from Bayer, because we were probably a little bit, well, I was certainly a bit confused at this stage, but Bayer put us in touch with expert opinion leaders and clarified a lot of things for us, so that was really, really beneficial working with Bayer.
Absolutely.
Some of the other things that included investigations for cancer. I won't go through the whole slide, but I think one thing to point out, NICE are very good at saying consider doing things, and that seems to feature quite a lot, but just say consider these things. There was thrombophilia testing, we've covered that as well. Again, consider testing for that.
So, Andy and I, from December onwards of last year, December 2012, spent many hours in each other's company coming up with a new pathway, which we think, that's the page, and it's both for enoxaparin if they still want it, or rivaroxaban, and it's a lot easier to follow, and it follows new NICE guidance. And looking into a little bit more detail, that's the second page, which was a handheld record that we give to the patient, very easy to fill in, and that's what they take for their scan, and the radiographer writes down the report and brings it back to you so you know what you need to do. And looking into more detail, you do a 2-level DVT Well Score. If the patient has 2 points or more, scores 2 points or more, it's DVT likely. If it's 1 point or less, it's DVT unlikely. And there are people who can and can't take PACE in the pathway, and it's what you'd expect basically. People who are pregnant wouldn't do it, if they're under 18, etc., etc. And looking in a bit more detail, you've got 2 streams, very easy to follow. There's not lots of lines going all in different directions and things. The pink side is if they've got DVT likely Well Score. You pick up the phone, organise a scan, you take some bloods, but you don't wait for the results to come back. If the D-dimer is raised and it's a negative first scan, you stop their treatment and you then get them to come back for another scan in a week's time. If that's negative, you say that it's unlikely they've got a DVT. If you see someone who you really think might have a DVT, but it's DVT unlikely with the scoring with Wells, you can take a blood test, and if the D-dimer is raised, you can then stick him through the pathway, and that's on the blue side. And it is easy to follow, and it does follow NICE guidance, which is important. So, that was our new pathway that we managed to put into fruition in a very short space of time.
Yeah. So the plan was to get the pathway accepted and use in County Durham and Darlington as soon as possible. Get it accepted hopefully further afield, and we're very willing to share the work that we've done, and we've tried to do that wherever possible. So we've done that across the north of England, and everybody's now in the north of England in receipt of our plan. But we'd like to take it further across the whole UK, the universe. And we'd like to consider, I think there are other things, we've taken it so far, but the things you can do with near-patient testing for the D-dimers, etc. And some CCGs, I know, are considering getting their own scanner for doing the ultrasound. So, you can take this as far as you'd like, really.
We actually launched in Darlington the new pathway in April of this year, and it's been a success. Had no disasters, everyone's kind of got on with it well, and the GPs in Darlington like it very much compared to what they had previously, and it saves a lot of money and you don't admit the patient who's got a likely DVT to hospital. It seems to be a win-win situation, easy to do and very cost effective. So just the key learning points and barriers that Andy's going to talk about now.
Yeah, we learned a lot from the pilot, and we really tried to communicate as best we could, but it still didn't work. Not as effective as we would have liked. You've got to be prepared for committees you didn't even know existed, but we've been to them all. One thing you've definitely learned is you can't please all of the people all of the time, and we didn't. Somewhat disappointingly, even though it's NICE approved, it didn't open all the doors which we thought it would do, and I think that's a bit of a shame, but it's a challenge. Perseverance, I think we showed great, tenacity in trying to get it through, but we were both determined that we weren't going to get stopped by this, so perseverance was a key watchword, I believe.
I think to put things into context, the existing old pathway using enoxaparin and warfarin took over 2 years to develop in Darlington and County Durham. In December of this year, we sorted out the new pathway, and it was launched in Darlington on April the 1st. So that was quick. And just looking at the timeline, I'll not go through the dates, but you can see for yourself how quickly we got the pathway, the pilot sorted out, and that was when the new pathway was launched in Darlington. Before we finish, as well as being club doctor for Hartlepool United and being an experienced GP, quite a few years ago I used to do a medical column for a local newspaper called the Northern Echo. It's a northern daily newspaper, and I used to kind of give an opinion on certain subjects and things. And I used to answer letters from patients who used to write into the Northern Echo asking for my advice on certain things. I was called Echo Doctor, and I used to think I give a good service. And there was one letter that I got quite some time ago that I was never able to answer properly, and I'd like to share it with you. And if you could give you some help in answering it, I'd be most grateful. Dear Echo Doctor, when I was young, I used to wake up each morning with an erection, and I could not bend it. Now I'm 73 years old, and I still wake up each day with an erection, but now I can bend it. Am I getting stronger? Yours sincerely. And if you've got any answers to that, I'd be very grateful, please. If you've got any questions, please don't hesitate to ask Andy. Thank you.
Thank you.
Well, thank you very much for an interesting and, may I say, entertaining talk. There will be a few questions, I no doubt. Please wait for the mic. That chap at the back first.
Hi, thanks for that. Rob Childs, GP in Dorset. What do you do about the patients that present and you're giving them the rivaroxaban right there and then? Are you prescribing a whole box, or are you just taking some out of the drawer, or what are you doing? Because you might not be carrying on for more than a day.
I should have mentioned that in Darlington we've been given a sample pack which we give a week's supply to the patient. It's from Bayer. You give them a week's supply. If they turn out to have a negative scan and you don't rescan them and they've got negative Ddimer, they just stop taking it basically. So the prescriptions, the cost only starts happening, unlike enoxaparin, when they actually need to kind of carry on with it basically. So that's what we do there.
I believe there are, we've obviously been in discussions with Bayer, and there is a weekly pack coming out, and I think that's going to be maybe a couple of months or so, but that would be another option as well to prescribe in the future.
Thank you both for that very interesting talk and telling us your success story. I'm John Ribchester. I'm a GP in Whitstable, where we have a large practice in our own MIU, in which we've tried to set up a DVT pathway, but hit problems with the local hospital trust. The problem they've allowed us to go ahead with a DVT exclusion pathway, which doesn't involve dosing with anything at all, including rivaroxaban. And they've spoken against us using rivaroxaban as a first-line treatment unless or until we've got near-patient testing for EGFR and platelets. The argument being that you might cause a bleed where you don't suspect or know about a problem. We strongly suspect there may be other issues which make them take that stance. Did you encounter that problem, and do you have any advice for me, please?
I think, we certainly did. We did reach the same problem, and nobody would ever admit it, that it was the INR service which they were trying to protect because it was bringing income in. I'm very good friends with some of the people at the Trust, and now I can get a wry smile out of them when I quiz them about it, but they never have admitted to that, but I can tell by the look on the face that was certainly an issue. And I think we were lucky in that we had already an existing pathway which was treating people in primary care. So really, to my mind, all we were doing was swapping a treatment such as warfarin with a treatment which is backed up by NICE.
I think if you see someone, unless they've got very severe renal dysfunction, they would just get a dose of rivaroxaban, 15 milligrams anyway, and they would continue with the lower strength if they did have renal dysfunction. And the existing pathway, you'd give an injection of heparin rather than wait for bloods and things to come back. So I don't think, they agreed to it eventually. But I think what Andy says is there was resistance because they saw their potential income going down. Although DVT for I&R clinics was never a major player anyway, I don't think. Far more AF patients.
But
I think we'll just take one more question and then that's up to time. So.
Hi. If your local hospital has started fragment after a total hip or a total knee replacement, and it has to be continued for 30-35 days, especially after hip replacements, do you change over to rivaroxaban?
The local trust to pay for that prescription and let them sort that out. In our local trust, we don't take over the care of that in primary care. I don't know the answer to that and as to whether they should be looking at that themselves, but we don't pay for that, do we, in primary care?
No, I think if there's any complications, this primary care pathway is very much for simple, clear-cut cases. If there's any complicating factors, then we would revert that back probably to the acute trust, I think.
Absolutely.
Okay. Well, thank you very much to both our speakers again. Thank you to Bayer for both sponsoring this session and sponsoring the event in general. And thank you all for coming in your questions. There's going to be a regional networking session for the East Midlands region taking place at 4 o'clock. So just to let you know, in case you're an East Midlander. I don't know what they look like, but anyway, thank you very much.